So as we continue to do, we are here to demonstrate some of the concepts that we've spoken about over time in specific areas. So this time what we're going to do is we're going to specifically look at the SCM muscle. But before we do any of that, one of the reasons that you will often see treatment of the cervical region or the region of the neck done in a supine position as opposed to any other is, again, when we consider our concepts of patient positioning, so the table makes stable, so in this case the patient is quite stable, especially the cervical region, because both the shoulders and the head are supported. The cervical region, or the cervical region, depending on how you prefer to say it, will have the opportunity, if you pillow appropriately, to essentially be free, so it's accessible. Now, not everything is visible, so we talk about the anatomy that you want to work on being exposed, free to move in the planes required, and preferably visible. So it's not absolutely visible, especially from at the head of the table. The other thing is that in a supine position, because the patient's well supported, they don't have to put a lot of effort into controlling their own neck. When they're seated upright, they are going to attempt to control their neck on some level, whether reflexively or consciously. So the supine position ends up being quite advantageous for treatment of the cervical region. Now, the SCM specifically, because we're talking about a soft tissue, we essentially want to know fiber direction. So where is it? Where does it start? Where does it run from? So essentially the mastoid process to more or less the SC joint, right? Now, or the sternoclavicular joint to be more explicit. So basically you've got a mildly angled piece of muscle here. Depending on the person, it will be easier to visualize than in others. That doesn't necessarily matter because it's essentially like a pipe and the fiber direction is more or less vertical. So to identify the SCM, one of the things that you can do, you can see how I'll basically take the middle finger and the index and create more or less a V. So they end up acting like scissors, like chopsticks, or like things that will come together and touch whatever's in between them or contact whatever's in between them. So I can identify the mastoid process. So basically if I'm around the ear, as I come in, I'm going to feel a bump or a protuberance, and that's going to likely be the mastoid process. Now, the reason we want to do this, we talk about palpation, specificity is not the number one necessity, movement is, right? And move from the known to the unknown, as well as get as much as you can touch. Get as much as you can touch relates well to broad contact for multi-point discrimination. So all of that comes together. Basically, I go to the area that I think the thing's going to be in. I find the most relatable bony protuberance, which happens to be the mastoid process. So I know it's around the ear. So if I use my whole hand, I come into the ear. And then as I'm around the ear, I'll find a bump. That bump is the mastoid process. It's the top of the SCM. I'll use my two fingers, make a peace sign, and then I'll be here. As I do that, there's going to be some mix of varying layers of tissue, so skin, subcutaneous fat, no matter how lean a person is, you're going to find some of that, and then the muscle. So basically you'll find a pipe, right? Now once you've found it, then, right, so I've got my boundaries, I can change my grip, right? So basically you can do it like somebody's pinching a kid's cheeks, right? So I can identify here, I can continue this way, so kind of a push and a pull, so working perpendicular to fiber direction. I can change my grip so that I have more contact on it. So the thumb going down, I'll have more contact on the SCM, and then this portion of my hand can be extended as well, so I can be on the posterior surface of the SCM. I can turn the head to soften, to expose it, whatever I need to do, depending on what that SCM happens to be doing, right? But again, to find it, broad contact, find the mastoid process, make a peace sign, I've got it, right? Or I'll more or less have it. Then I can change my grip if I want to push and pull, right? So perpendicular to fiber direction, I can generally move the head, right? So relational motion. If I move the head in relation to the still thorax, or in relation to the still clavicle, what I'm doing is I'm moving the mastoid process in the superior attachment of the SCM in relation to the inferior, the SC joint, right? So the head can move and thorax stays still, which means that the top of the SCM will move while the bottom will relatively stay still, or the bottom anchor. So I can soften the tissue up as I need to. I can create more tension in it as I need to. Pushing, pulling, right? So relational motion, the head in relation to the still thorax, and then relational motion, that the muscle in relation to still bones, the still muscle in relation to bones, right? So I can continue to use these concepts over and over again. The reason that I would tend to work on one SCM at a time if I wanted to use mixed leverage, so short lever on the muscle itself, long lever the head and neck, is because, first of all, it's a little bit easier, right? This becomes cumbersome, so I can do this, but my hands move in relation to the SCM, so I can't get as good of a general contact or control on it. So I'm going to work on one. The other thing is that as you put tension on both SCMs, either anterior or posterior, you can start to apply pressure or differing sensation to the anterior surface of the neck, which may make some people feel fairly uncomfortable. They may feel like they need to they're choking, they may feel like they're gagging, they may just not like the feeling, period. The other thing is with the SCM, you want to be careful because there's quite a bit of neurovasculature that runs directly beneath it. So the vagus nerve is essentially directly beneath it, the common carotid, the carotid bodies. So you want to be careful here that you don't just really bite down on that muscle or affirm with that muscle. This is a muscle that, whether or not you have a large impact on physiological responses by moving the muscle and essentially its related neurovascular contents, whether or not you do have a large impact, it's better to be smart and not try to have a large impact, because just in case you do, you could cause a lot of trouble for an individual. So it's an area that it's smart to be gentle with, and it's smart to be safe with. So you can work on both SCMs, so you can kind of do a comparison side to side, see which one needs more work or which one is higher tone compared to the other, see which one requires more attention, and you can make your choice. I wouldn't do this necessarily, again, because it's just too easy for somebody to feel uncomfortable. If you ask and they feel fine, you can go ahead and do it, but you'd want to communicate with them because you may not get the signal that is giving them problems. But again, your very simple search strategy, broad hands, come below the ears as you kind of cup beneath the ears. Your fingers are probably going to hit the mastoid process. Peace sign, right? Scissors, chopsticks, whatever you want to say. You've got it. Change your hand. You can work on it now, right? So all of that rambling to essentially tell you that you move from the known to the unknown. The known happens to be the mastoid process. The thing that's going to be beneath it in a pipe-like structure is going to be the SCM. You find the pipe by identifying its posterior and anterior border. This is an easy way to do it. Deuces. Right? You find that and you can change your grip as you need. And then you've got relational motion. Still bones, moving muscle. Still muscle, moving bones.